Just assess their ABCs, okay? Sensory motor checks. Why is that not the most important thing right now?
Because it could change. Especially if like your spine's not stabilized, you can cause further more injury. Those would wipe out and you have to redo them anyway.
Okay, so when my patient initially comes into the emergency room, I have some swelling and some edema right there. So hopefully over the next few days with some treatment, my symptoms are going to get better. So that's a priority, but it's not the main one. Assessing level of consciousness. Is that really the priority?
No.
No, because if I don't stabilize their spine, I'm preventing a secondary, I can prevent a secondary injury by stabilizing the spine. So that has to be the priority. And as soon as I know that that's cervical spine or whatever is stable, then I'm going to assess their level of consciousness and their sensory motor. But yeah, preventing skin breakdown, way down the list.
Sodium because of MOC, hypoglycemia, urinary tract because of infection, because of cognition. Common sense. It took me so long.
It took me a minute.
Okay.
That's like
hypokalemia affects what?
Heart.
Hyponatremia,
LOC.
yeah, your level of consciousness. It can affect your mentation. It can affect your seizures. Can this be true if it's hypernatremia?
Yes.
So any change in sodium, high or low, can affect it. What about hypoglycemia?
Yeah.
Low blood sugar. Right. Geary won't let us eat. Yes. Hangry. Urinary tract infection.
Oh, yeah.
How many old people come in the hospital and they're crazy?
A lot.
And once you clear up the urinary tract infection, they come back. So, right, every single one from the nursing home. Either constipated or an UTI. My first job was geriatric floor in the hospital. I know these things.
Mm-hmm.
Great. Okay.
Ooh, I know this one. Like what? So Brayden was stroke, of course. Lasco was consciousness. It wasn't long.
I think that's the face.
Yep, it is. Hey, we all got it right.
Scale, you know?
The faces.
Yeah,
The faces.
The faces that they use for kids. Brain scale.
Skin breakdown.
Ooh, what is this one? Stroke scale. Stroke scale. You don't know anything about it yet.
How bad they are.
After we come back from spring break.
I know it. 'Cause I
Nobody's
took that
happier
stupid
about that.
test.
Okay.
It's the brain. They maintain normal. It says not regarding. Because they actually boost up the blood sugar. Eliminates too definitive.
Which
You
one's
can't
not
eliminate
true?
anything.
They can meet
Never
the
choose
caloric
one.
needs of the
They can
patient.
still aspirate.
Maybe not 100%, but they're going to give the patient some caloric intake. Okay. If I'm giving enteral feedings, what kind of feeding is that? Tube feeding. Parenteral feeding is TPN through their IV, but this is tube feeding.
Oh, okay. I'm thinking
So I can maintain glucose levels with that feeding. Because remember when I told you in level 2, there's a
Watch
feeding
for
for everything.
hyperglycemia.
There's one for liver patients, kidney patients, diabetics, regular folks, everybody. High calorie, high protein. So we can get their normal glucose. What was the other one that you didn't pick? If I don't use it, I'm going to lose it,
Yep.
right?
Yep.
So if I have bowel sounds and if I have peristalsis and I use a tube feeding, I'm preserving the integrity of the GI tract because I'm using it. This one right here, how come that's not true?
It definitely doesn't. You have to keep it together.
Okay, so I'm putting them on this diet because I'm afraid they can't swallow, or I'm afraid that they're gonna aspirate when they do swallow. But if I don't do what I need to do, taking care of them with the tube feeding, they could aspirate anyway. So like she said, when I'm turning them or changing the bed, I need to make sure that the tube feeding's off when their head is down. Things like that. Make sure that if I'm using an NG tube, it's placed where it's supposed to be placed. Things like that. We'll talk about all those altered diets again in here.
Wait, Mental's diuretic. Dang.
What?
Blood count, I think.
CBC, you always get a CBC, right?
I make things with lung sounds.
That's what
But
I
it's diuretic. Yes, CBC.
I was right.
Okay,
necessary assessment.
so you all know that urine output is important because
Yeah.
this drug does what?
It's a diuretic.
It decreases your blood pressure. It makes you pee. It's an osmotic diuretic medication. So we expect them to have good urine output. That's an assessment we want to do. Skin turgor, I don't know who picked that, but why would you not want to assess that? Because if I'm all of a sudden giving you a diuretic and you're putting out copious amounts of urine, could you not become dehydrated quicker?
Yeah,
So would skin turgor be something I'm concerned about?
for sure.
CBC doesn't affect that at all, don't care about that. Lung sounds.
Oh, yeah.
Right.
Fluid buildup.
If my kidneys are not working, when I'm pulling all this fluid into the vascular system and my kidneys aren't working right, and I walk past my patient's room and there's no urine in the bag, or for whatever reason they haven't had any urine output, where's that fluid all going? Their lungs. So what's their lungs gonna sound like?
Crackling, crackling.
All right, last one.
Like a crackling. Let me see. I thought diazepam was long term.
It has long term. That's what my mom's on. Diazepam is Ativan.
Okay, diazepam. Diazepam and lorazepam are the only two drugs that we give to
Someone
stop
logged in
seizure
from Mobile.
progress. Okay, all the rest of these are seizure medications that your patient's on. I had a seizure, and now they don't want me to have another one. So these are all preventive seizure medications. This one's Keppra, can be given IV. This one is a synthetic form of Dilantin, can be given IV, and clonazepam is PO. Okay, so see, you remember some things, and now you kind of know where we're aiming. Okay, who is this person right here? Huh? Who is that?
It's gotta be someone.
That's weird.
That's fine. So we have, who has their syllabus with them? Can I see it real quick? We're gonna tie in some things that we covered in level 2, but there's a lot of things that cognition in level 3 kind of stands on its own.
I think I have it.
So,
You got it?
we're going to talk about the test. We're going to add the stroke scale in this semester. You have to know a little bit about anatomy and physiology and the nutrition. Do you think you have to know about geriatric patients?
Yeah.
Do you not like old people?
No, not really.
She doesn't like old people. I saw it in her face. But you do have to know how to take care of them. And if you can't take care of them, if you don't know what's normal, what's not normal. So that's why we have to do that. Testing, things like that. We're going to talk about those. Okay, so for your patho and all these content topics, we're going to talk about seizures in how they relate to strokes. So we're not going to go back and talk all about seizures again, but if you have your stuff from level 2, you might want to look at it because we're going to incorporate some of that into what we're talking about with head injuries and strokes.
We're going to talk again about multiple sclerosis because we just briefly touched on it. We're going to talk about all the medications and things. We're going to talk about spinal cord injuries. We're going to talk about some special brain tumors that you need to know about. But in here, strokes are your biggest thing, and I really hate that we have our lecture before you go to ASLS. But we're going to make the best of it and work around that. I'm going to do the quiz that Ms. Cooper made for you to see what you're supposed to know before you go to ASLS, and then I'll readjust the lecture accordingly. Do you have a question? Because ASLS really talks about the identifying the stroke person, getting the help you need, and then the care that they receive like in the first couple hours of the stroke. And we're going to talk about that too, but we really care about what are you going to do that first week when that person's in the hospital, and then what are we going to do for them afterward with their deficits and their rehab, the things that we need to consider. So, because there's more to taking care of than in that first fun, exciting few hours. You know, you're going to learn when you go to ASLS that strokes are one of the leading causes of disabilities and one of the most expensive things that affect the family economics in taking care of someone who's had a stroke. But we'll readapt after I see what she has on your quiz for you. And then the other thing that's new on here that we only talk about in level 3 is this eye and ear thing with Meniere's disease and with retinal detachments and corneal transplants. And so our stuff is kind of chopped up. So today we're going to do the eye and ear thing. Whose was this? So let's talk about these normal changes that your patient has with the eye and ear thing. Who can remember anything about your older adult patient with the changes in their vision?
Glaucoma.
Okay, glaucoma. What is glaucoma? The pressure in your eyes. And they treat that with drops. Okay. Do you have to be old to get that?
No, my sister has it.
Yeah. Yeah. Anybody can get that. What are changes for our old people? Cataracts. What happens when you get cataracts? The buildup on the lens. It's not on the cornea. It's on the lens of your eye. How do they fix that? They take the cornea out and they give you a nice glass or plastic one and stick in there. Is that common surgery? Usually affects people usually over 60. It can be a little bit younger, but usually over 60. And it is done as an outpatient procedure. You're wide awake when they do it. They numb. Yeah, you are.
Can you choose to?
No. You're wide awake. They numb you up with all kinds of eye drops.
Do they need you awake for one? Is that why?
No. It's not. My husband's had it done. It's not painful.
Huh?
Just having somebody.
Yeah.
What are we talking about?
You can't feel it. You can't see. They have your eye dilated. You can't do anything. So
That's retinal detachment.
that's outpatient. Super easy to take care of. And you don't even do that though, Reggie. When they come at you, you don't even do that.
Yes, that's it.
What other changes for older people? Have you ever? Okay, macular degeneration. Their eyes just aren't functioning the way they're supposed to function. They can't see. They lose their field of vision. Have you ever seen in a restaurant where it's kind of darker, setting the mood, and they're like this with their phones, like holding it up to the menu? Because they can't see in the dark. Because their pupils, they don't constrict and dilate the way they used to. And so they take a long time to readapt to light. So when you're looking at this paper and the light's real low, they can't see. Or have you seen them go like this?
Yeah.
Because they can't see close up anymore. Like when you have it close up, it's real cloudy, so you hold it farther and farther away. That's why after they have cataract surgery, all they need is readers. Because they can see long distance, but they can't see close up. Have you ever seen an older person and that bottom lid is kind of saggy and you can kind of see the
Conjunctiva.
Conjunctiva of their eye? Well, do you think that's a problem with dry eyes? Yeah, so they have a lot of problems with dry eyes, things like that. Or what about the person who has the lid that droops down over
and they can't see, and then they have to get the lift to get the lid back up.
Poor
It's
thing.
a problem with it causes a problem with their vision. Let's see. The cornea gets flattened. Ugh. And what about their eyes when they look? Have you ever looked at them and the white part of their eye either has a yellow tint to it or a blue tint to it? That's fatty deposits in their eyes. Do you think those have an effect on their vision? Yeah. So they have some problems. I was gonna take a picture of it, but then it didn't turn out, so I didn't. I take 2 medications. They look exactly identical, and they're almost the same size. One is my Claritin, looks like a little white football. One is my Losartan, looks like a slightly bigger white football. The only difference really between them is one has a different number than the other one, okay, like a little identification number. So if I had trouble with my vision, do you think that as an older person, I might mix them up and take the wrong one? Yeah. I just noticed when I picked up my last prescriptions at Keesler, the labels now are written in, I'm going to say font that are like this big. You know what I'm saying? Yeah, it's huge. And they said our older patients love it because they can see, and the older patient can ask for the bottle that is not safety, child safety. But it's still, to identify between those 2 pills, I could really mix them up if I couldn't see or feel those pills. So that's why patients are non-compliant or possibly over-medicated, because they make mistakes. Yes?
My
Jasmine?
boyfriend's dad actually went to go take his allergy medicine, and his wife takes blood pressure medicine, and they look the same, and he took it and passed out.
Yeah, mine look identical.
Yeah.
They look identical. One's a slightly bit bigger than the other one, but one is for allergies and one is for blood pressure.
I know uncontrolled diabetes. Is it glaucoma that it can cause? Or, okay, I didn't know what kind of eye.
No, it doesn't cause glaucoma. It causes diabetic retinopathy.
Okay.
Yeah. Same thing though. They lose their vision. Diabetes is the leading cause of blindness in the United States. Sad. The lens gets hard and they can't see as well. So we're going to talk about, I didn't put a little clicker in here, so I'll just change this. We're going to talk about the 2 vision-related disorders we have. You have to remember what the eye looks like to understand what these are, okay? I know that you learned all about this in A&P 100 years ago, right?
Oh, never
I know
forget.
it was 100 years ago. It was for me too. This is what we're most concerned about here, though. Let me see if I can get this little.
I loved my
So the cornea is what we're most concerned about, right there in the front part of the eye. And the cornea gets clouded over and thick, and your patient can't see, and they need a corneal transplant. The other thing that we're concerned about is the retina right there. You can see the retina that goes around the whole entire eyeball, and a retinal tear is a medical emergency. Because if you don't repair it, you're going to lose your vision in that eye. So those are the 2 parts of the eye that we're most concerned about. This is the corneal problem, and neither one of these pictures look great to me, but apparently when you have the thickened cornea, this is what everything looks like, especially in the dark. You can't make out any different structures, lights, things like that. Neither one of those look very good to me, but. So that's what we're going to talk about, is removing that cornea
Next to the last page.
and replacing that cornea. So where does a cornea come from? Like if I need a cornea replacement?
A donor, a body.
A donor. So it comes from a tissue bank where they have corneas that they can retransplant. Usually there's not a ton of time in between. So preoperatively, you got to do your teaching. You're going to teach your patient about eye drops for one, because infection. You don't want them to get infection in their eyes. What kind of things do they need to know about eye drops?
How to put them in right without.
Okay, how to put them in right.
Your email.
People don't like things dropping in their eyes, and so they're not careful sometimes. And if I'm putting it in someone else's eye, what if I go to put it in her eye and she blinks her eye down on the tip of my container?
It's gross now.
Right, it's contaminated. So you got to teach them. You don't share eye drops. You don't touch your eye with the tip of the bottle. You don't you don't touch the tip of the bottle because you're getting germs on it put in your eye. So you gotta teach them how to administer them and the safety things to prevent infection. Let's see. That's really the only thing they need to know prior to, other than what to expect for surgery, and they are gonna get some sedation, but they'll be awake. Like Versed sedates you, but you're still awake and you can follow commands like blink or move or turn your head to the right or left. This is how they do it, and I'm gonna show you a video of this. And I hate that it's 5 minutes long, so I'm gonna fast forward through parts of it. But the way they do it is almost like a cookie cutter. They go in and they cookie cut the piece out that they're removing. They have the donor one that is shaped with the same cookie cutter, and they go back in and put it back in over your cornea, and then they stitch it in place. So I'm gonna show you this video real quick and let you see.
Does it change your icon?
Okay, and I apologize because this has no sound, so we're gonna fast forward a little bit. So this dude's awake, by the way, just so you know. This kind of grosses me out too.
What did you say the name of the,
Somebody I know
Percentage
hates
driving.
eye stuff. Isn't that you, Tristan? Somebody I
You can't
know.
feel
feel
it.
anything?
You can't feel anything.
I bet it hurts like.
When you wake up, probably. So you can see it?
I mean, they do this outpatient in the eye doctor's office.
What? They do this in the eye doctor's office?
Yeah, even I am kind of grossed out by this.
Like, not one of these.
I feel like there's like a super high risk for
He's still
infection.
working on getting this out.
Oh, yeah. Because my mother-in-law, hers got infected after, yeah. She had like 4 or 5 different eye drops.
You don't have to know anything about cataracts in here.
So can this person literally see all this happening? Like, do you see all this going on in your eye?
They have it all numbed up and you can't see out of that. Because if you could see, you would be trying to blink.
That's what I'm saying, like, that's.
The eye sedated. Just the eye, you're awake though.
Your left eye's good, but that person's right eye.
See, there he's putting the thing in place, and then I'll show you how they stitch it in. Even though I think this is kind of gross, y'all. Yeah, it is amazing.
That's so crazy.
So see how they're just stitching it in with these absorbable sutures.
Oh, they absorb?
You see them like the stations in the ER or whatever. And that takes concentration,
That's their working is, like, it's just how they would mark your they mark your eye with marking, sterile marking. See how he's sutured in place though?
see that little baby needle?
My friend used to close her eyes.
Not even.
She would do it when I was sleeping at like
So can you see how your patient could get an infection in there easy?
Yeah.
Yes.
You know? Even just with the sutures.
Imagine them not wearing a
It's probably medicated. It's probably covered in some type of.
Okay, so, we shut that one off. We're gonna look at one with the red one. So, if I'm gonna take care of this person post-op, what kind of things do you think I need to think about?
Do they have a patch on them, or is it?
I don't know, do they? What do you think about a patch?
Yes, so they like rest that eye.
Yes, they want them to wear the patch, particularly if they're around kids, animals, when they're sleeping, because you don't realize how often you rub your eye, especially when you're sleeping. So they do want them to wear the patch at nighttime. What else do you think I need to think, teach them?
So when you're not wearing the patch, don't rub your eye.
Okay, when you're not wearing the patch, leave your eye alone. Don't sprinkle out your eye. Wash your hands. Okay, what were you saying?
Like lab operating equipment for surgery.
Okay, what do you think about that, operating equipment? Can they drive? Can they not drive? What?
They're only
No.
gonna for a while.
I mean, they probably run that after surgery because it's such a big first
After your first follow-up.
Right, you have to have somebody to drive you home from the clinic.
Yeah.
But they have their follow-up the next day, and they can drive after that. So they can't drive for 24 hours. But that is mainly because of the sedation that they had through their IV, not because of the eye. They can usually see out of the eye as soon as the local anesthetic wears off. What do you think about ice or heat?
No ice.
Why do you think not?
gonna dilate.
Okay, I don't want to use ice because I'm constricting the blood vessels, and I really want blood flow to that eye so that I can heal. So no ice. Do you want to use heat? Yeah, no heat. They don't need ice or heat. Do you think somebody needs to be checking that on every now and then?
Yeah.
Like, yes, either as I'm putting the drops in myself, I need to be looking in the mirror, or I need to have a family member check. Do I need to report any drainage?
Yeah.
Yeah. I might have some extra tear production for a little while, but if I have any kind of ooey gooey pink eye drainage, I need to let somebody know about it. We talked about the shield. What about
The shield.
the
Eye patch.
Oh, okay.
what kind of complications do you think I should tell them to report?
Shark pain.
Yeah.
Okay, if I can't see out of all of a sudden, I need to report and let somebody know. Because this procedure and cataract surgery increases your risk for a retinal detachment. So if all of a sudden I have a field of vision that I can't see out of a part of my eye, I need to let them know about that. What else?
Fever?
Fever, if I'm running a fever. Now, do you think my eye's gonna be red for a day or two?
Yeah.
If that persists, is that important to let somebody know? Sign of infection. Can I reject the graft?
Yeah.
Yeah, I need to know what to do if I have any signs of graft rejection. So what would that be? Pain, swelling, any kind of cloudiness over that lens, I need to let them know because I'm rejecting the graft. One other important thing, we have intracranial pressure that we kind of talked a little bit about before. What about interocular pressure?
Yes.
Mm.
Even built up on the eye.
Okay, so I don't want any extra pressure pushing on my new cookie cutter cornea. Okay, so what kind of things did I need to teach them to avoid to decrease interocular pressure?
Sleeping on that side.
Okay, sleeping on that side. Which side do I want them to sleep on?
Non-infected side.
The non-operative. So if I have my left eye done, I want them sleeping on their right side. So that side has less pressure. What else?
Bending over, what bending over?
Bending over to tie their shoe or work in their garden or pick up their 20-pound grandkid. Is that a problem? Yeah, we don't pick up our 20-pound grandkids. I think they tell them 8 pounds or something's the limit. What about blowing my nose? You know, allergies are terrible. I don't want to blow my nose. What if I have to cough or sneeze? If I have to cough or sneeze, how do I want them to do it?
Or close your eye.
Well, I want them to cough or sneeze with their mouth open to decrease the pressure. So that, yes, you know people who sneeze like that and they grab their nose so they don't make noise, which they still make noise, so why are you doing that? What about nausea and vomiting? Will that increase it? Yes,
Yeah.
so they'll probably send you home with a little bit of something, usually Zofran, just to make sure you're not nauseated. And the last thing, two more things. Activities. I'm a runner. That's a lie. But I'm a runner and just had eye surgery. Should I be out jogging? Should I be out doing heavy lifting at CrossFit? I don't do that either. I shouldn't. I can't do anything that's strenuous activity like that because I'm making the pressure in my eye higher. The other thing is, what about bowel movements?
Don't strain.
Right. I don't want to be constipated or be straining to have a bowel movement, so stool softeners, because every time I bear down to have a bowel movement like that, I can increase the interocular pressure.
So those are the things you need to think about when you're teaching your
Can you
patient
teach
about
us
this
illustration
surgery.
real quick?
I'm just gonna be honest with you, never taking care of a person who has had this surgery because it's done on an outpatient basis. But you never know, and it is on your syllabus, so that's what I'm talking about.
In our cognition syllabus.
Now, retinal detachment is a different story. Here's your retinal detachment right there. You can see where the retina is that yellow line, and you can see how it's normally pressed up against the outside of the eye. For some reason, air or blood or something has accumulated in there and caused that retina to pull away from the outside edge of the eye. So think about it like this. What do you know about chest tubes? You know when they put a chest tube in, you have your lung tissue and you have your outside, and that tube goes in that pleural space? This is kind of the same premise right here. So I can't put a chest tube in the eye, but what they're going to do is they're going to put a big bubble of gas in their eye to push that retina back up against the eyeball. So I'll show you what that looks like. This is what they look like when they have a retinal detachment. They can have floaters, little stringy things, patches where they can't see, or lose like entire field of vision in the eye. My dad had this. He said it was just like a black curtain came down over one eye, and it started, and then as the tear got bigger, he lost complete vision in that eye. But it is a medical emergency, so if you can't get into your eye doctor on the weekends, you need to go to the emergency room where they can get an eye doctor. And this is what they can do it two ways. They do the bubble of gas, they inject it in the eye, the bubble sits up there till it pushes it back up where it belongs, and then as it's decreased, if the bubble is still there, they'll go back in and pull the gas out or pull it out. They can also use a buckle up there. What they do is they put that buckle around the eye and pull it in until it reattaches, and then they take the buckle back off. They can do it one of two ways. I've only ever seen the gas one.
Do you feel pressure when they inject the gas in?
They say they feel a little bit of pressure because you have the blood in between. Let me go back. You have the blood in between the lining in there, and then I put the gas bubble in. So it's things in a space where there's only so much space. But your eye's pretty flexible. You know what I'm saying?
Yeah.
It's not like the brain. It's pretty flexible.
So does it like push the blood out?
Yeah, where does the blood go?
It resolves, just like when you have a big old bruise under your skin, eventually it just resolves. So let me show you this video of this, this one's disgusting too, just.
Wait, what part is bleeding? I missed it.
I don't know. I didn't hear it.
When they inject you with the gas.
You're awake, but you're,
Yeah, they
yeah.
numb you.
Oh, sorry,
I don't know.
sorry, I gotta get out of this stupid PowerPoint. Okay, hold on, I'll go back to the beginning. I think this one doesn't have any words.
She said something about scleral buckling.
That's like a laugh. Yeah. That's cool.
I really don't know if I could be fucking with the eyes like that.
It looks like it feels really good.
It looks like it makes my stomach a little.
You can work in an eye clinic and be
Just
the
makes
nurse
my eye
who does
hurt.
it. You can see this all day long.
They do sedation, they just push percent of fentanyl. Yeah.
That's it.
How much pain do they experience after this is what I want to know.
Probably not much. They got them pain meds.
What about the little, is that the sedation they
He's
do?
injecting gas in there.
What was the thing before that?
The sedation is there?
Wow.
Oh my gosh.
See, you can see on this, I think the tear's like right here, and as they're bubbling it up, you'll see that it opens back up a little bit. Mhm.
I'm so glad I'm not an eye doctor. What do they name it? eye doctors that do just do surgery for eyes. What is the
It
name?
depends on how big the bleed is, how big the tear is. There's another video out here on YouTube, but it's
It's
not
not
10 minutes long.
ophthalmologist.
But it has a big tear, and then the eye doctor
Is the surgeon?
cleans up the
Or
tear.
does the doctor do that?
So they lost eye tissue,
Yeah,
so that's
I
when they
think the
use the
doctor
buckle.
Yeah, I
You
don't
know
know.
what I mean?
So the doctor is a surgeon?
Yeah, I think so.
Your doctor.
Well, because the other day I was talking to my eye doctor about clinicals or
Anyway,
whatever.
pretty cool.
And he was telling me how some surgeons to him are still a dick because he's not a surgeon. So I was like, maybe you have to be like certified. Like you can just be an optometrist.
So, what kind of things do you think you need to think about when you're taking care of this person that just had this retinal detachment done?
An eye patch as well.
Okay, an eye patch as well. And they do have them wear the eye patch for a couple of different reasons. And they ask them to wear it for longer because anytime the patient is watching TV or reading a book or whatever, what is your eye doing the whole time? Moving. And as my eye's moving the whole time, I'm putting stress on the tear and the bubble. So they do want them to wear the patch for the retinal detachment repair to rest that eye, to keep it from having that intraocular movement consistently. What else do you think you need to think about? The same kind of things. I don't want to increase pressure, so all of those things are still pertinent. Sleeping. How do I want to sleep?
If gas or oil position patient on
Does that make
abdomen.
sense? How do I want to sleep? Okay.
In your
if you
stomach.
hit on where my tear is. If my tear is in the back of my eye and they put the gas bubble in, how would I want to lay? On my back. Where would the gas bubble be if I'm laying on my back? Forward. My tear's back here. In the back.
So you want to lay on your
So you have to lay.
stomach?
Only a
This
50
is one of the big
side.
differences.
Oh God.
The position that they want you in to keep the gas bubble pressed against the tear. So it depends on where the tear is, how they want you positioned.
Oh, that's miserable.
Yeah. Can you
Like when my
imagine?
dad had his, he had to be like face down, like all the time. It was terrible. So see how he's face down? This
I'd go get a
one's tear is
massage.
probably on the back part of their eye. This one's tear could be anywhere on the side, up higher in the eye.
Wait, I thought the tear would be on the front part because the gas bubble would be behind, correct?
Gas bubbles move.
The gas bubble, what's going to be higher? Your aqueous fluid in your eye or the gas bubble? Which is going to weigh more? The gas bubble is going to weigh less. So it's going to be
So
pushed
it's
to
gonna
the top.
move. Yeah.
So to keep the gas bubble against wherever the tear is, I have to lay so the gas bubble is
So if
up,
it's in the back,
pushing
you lay
against
like
the
this.
tear.
Right?
So it just depends. This one, his tear is probably on the back part of his eye.
Yeah.
Because as he's laying down, the gas bubble's
Floating that
up,
way.
pushing the retina back against the eyeball. Does that make sense?
Yeah.
Okay. So that's a big thing. The other big thing is you cannot fly when you have this done. Get in an airplane. Because what happens when you go up in
The pressure.
increased pressure, you cannot get in an airplane and fly
I feel like
until
that
the
would
doctor
hurt.
releases you to do so because of the chance of that gas bubble. I don't know if it would explode, but it would definitely increase the pressure, just like it does in your ears when you fly. So I've only ever seen this done in an emergency situation, because usually it's done in the eye doctor's office, but on the weekends they'll do it in the hospital. Like they'll come in and do it in the eye doctor. So, any questions about taking care of somebody with intraocular pressure problems?
How long do they have to sleep like that? Just until the doctor releases
Until
them?
it's resolved, until the doctor releases them. They don't have to be in it 24/7.
If it's in the back,
But
you
it's
lay
not
like
doing
that
any
because
good
it pushes
if I'm
back. The
upright
bubble's
all
gonna
the
float
time
up.
and I need to be face down. You know what I'm saying? So you have to be in the majority of the time. Think about sleeping like that.
Nope.
I'm used to sleeping like that.
I know it's weird though. When I was pregnant, the only thing I wanted to do was sleep on my stomach.
So
and
the
I could not.
hearing disorder that we have to talk about, let's talk about Meniere's disease real quick. And I want to get this done because we only have an hour.
Right here.
So we're almost done. So, normal changes with your people's ears.
Did you ever notice old people have long earlobes?
Yeah.
Yeah, the earlobes, the pinna elongates, and they have long, they look like their ears have grown when they get old like
Don't
that.
the ears never
How
stop
about hair in
growing?
the ears? Let's trim that.
Oh God.
What about the wax? What's the wax in your ears like?
No.
Okay.
Lots.
Extra wax is hard and dry. Does that affect their hearing? Yeah, that can affect their hearing. It could just be a matter of that they need to have their ears washed out by an ENT. What about the tympanic membrane though? It gets hardened. Is it fluid so the sounds aren't the same? So they kind of lose out on the high pitched sounds. They lose the S's, the F's, the PH sounds like that, and the hearing acuity. Oh, and let me tell you these two charts. The normal aging for the eye is 46.1, and then for the ear is 48.1. And those are just your normal variances for the adult ears. 46.1, 48. So you can look at them. There's like a list of 7 things. So this is what we're going to talk about is Meniere's disease. Anybody know what Meniere's disease is? Anybody know anybody with Meniere's disease? Okay, it's the big symptom is vertigo, and it is in the inner ear. It's not an infection of the inner ear, though. This is normal, where the labyrinth of your ear is, but then when it's full of fluid, not infection, just fluid, lymphatic fluid, it causes you to have nausea, vomiting, ringing in your ears, which is called what?
Tinnitus.
Tinnitus or tinnitus, either one, and vertigo, which is severe dizziness. Remember when you were a kid and you used to spin around like in a circle and then you try to walk
I
and you'd
still do
stagger
that
all
with
over
Blair.
the
It's a bad
That's how
idea.
these people live their lives. They have attacks 1-2 times a week.
But
So this is what it looks like.
I do that with Blair, and then I always
When they get
regret
up
it
off the
because I
couch,
feel like
the
I'm
room
gonna
is
puke.
spinning. Outside, the room is spinning.
No, thank you.
They have trouble with balance. So what do you think as the nurse might think is safety?
Fall risk.
Fall. They're a huge fall risk or a risk for injury because they don't have balance, or good balance. The ear feels full. They have ringing in the ears. Is that comfortable when your ear feels full?
No.
It's a lifelong disease. Here's the deal. If you have a family member who has it, you have a 33% chance of getting it yourself. So there is a familial
Tristan, who'd you say
tendency
has
to
it?
Very specific.
My mom has vertigo.
Well,
Does she have that? Meniere's?
Oh,
Hold on. This special diet that they put them on is called the high drops diet. It is whole grains, fruits and vegetables, no salt, because what does salt do? Increases fluid. It's really, truly a good example of like the Mediterranean diet.
Whole grains.
Some people say that it helps. Some people say that they're not going to do it. And some people it doesn't help. So it's something that they do try.
Hydrox has whole
There's
grains
also,
in
it
it.
doesn't talk about it in your book,
You're supposed to eat it.
different positions that they can teach people that decrease the amount of fluid in the labyrinth of their ear, that decrease their symptoms. Patients say that works really well. Unfortunately, it's not talked about in your book. We're not going to talk about it too much. Here's the medicines I want you to look at though. Atropine. What does atropine do? Dries you up. So what does that do? I'm already dizzy and stuff. You're drying me up, and now I'm dehydrated. It could make it worse. It could change my level of consciousness. What about your antiemetics, particularly Phenergan or promethazine? What does that do to you when you get an IV? Sleepy. Makes you sleepy. I'm already a fall risk, and you're drying me up and treating my nausea with Phenergan. Does that increase my risk for falls and injury?
No.
And even antihistamines like Benadryl, especially your older patients, if you give them Benadryl, it makes them a little bit loopy sometimes. So they're real cautious about that. But these are the drugs. You need to recognize the name and think of safety things. Okay? That's the only way I'm going to ask you questions about them. You recognize the antihistamine and you're thinking of safety with your patient. Antivert is the drug of choice to treat this, meclizine. What's the drug choice? Let me just tell you this. A labyrinthectomy is the treatment, a permanent treatment. Here's the problem.
You can't hear it then.
You will not be able to hear. And usually if I treat one ear, this will go to the other ear. So your patient has a big decision to make. Can I live with the symptoms of this and work with the treatments? Or do I want to do the labyrinthectomy and have a permanent loss of hearing in that ear, knowing that it could go to the other ear? So they just go in and they remove the whole labyrinth.
I didn't write all the
Patient no
meds
longer
down.
hears.
There's no safety.
So what meds?
We're not gonna talk about brain tumors today.
Should have said all the meds for it. Make sure you.
But
know
those are the
safety.
things you need to read about in your book.
Alright.
There's a whole chapter on, 2 chapters on eyes. Focus on the normal changes, corneal transplant, and retinal detachment. In the hearing chapter, normal and Meniere's disease. That's it. When we come back next week, or Friday, we'll talk about spinal cord and multiple sclerosis.
Can't wait.
Friday after.